The next sign everybody was this geographic atrophy. So to understand geographic atrophy, let's understand with time, in late stage, with time, what will happen, everybody, these lucens will keep on growing larger. When these lucens keep on growing larger, they will coalesce. When they coalesce, they're so to understand geographic atrophy, let's understand with time, in late stage, with time, what will happen, everybody, these lucens will keep on growing larger. When these lucens keep on growing larger, they will coalesce. When they coalesce, they are putting pressure on the RPE. When they put pressure on the RPE, they are basically destroying the RPE from below. If you don't, okay, thank you for the thumbs ups, Jinal, Mira, and Ajay Kumar. Thank you for letting me know that you understand this. Very good, guys. Okay, so geographic atrophy is large area of RPE atrophy. Okay, so these are all the signs in your dry stage or the non-exudative stage. I hope there is no confusion about this. Done, everybody? Now let's move on to the understanding first of all, treatment. Okay, everybody, treatment of dry ARMD. So basically, we have done the classification, we have done the signs of dry ARMD. Now we are doing the treatment of dry ARMD. So please remember, in dry ARMD, our main aim is to stop the progression of the dry stage into the wet stage. We need to stop the progression from the dry stage to the wet stage. Now, we know that there is one risk factor. What is the risk factor? Smoking. When we know smoking is the risk factor, we know that smoking decreases the levels of antioxidants. And that is why the treatment of dry ARMD, to stop its progression from dry to wet ARMD, we are giving antioxidants. Now the question comes, which antioxidants are given? So everybody, vitamin to wet ARMD, we are giving antioxidants. Now the question comes, which antioxidants are given? So everybody, vitamin A, C, E. Out of the three, which of the following is not given? My question, which of the following is not given? Option A, option B, option C. Which of the following vitamin is not given for the treatment of dry ARMD? Anybody? Let's start a poll, guys. Which vitamin is not given for the treatment of dry ARMD? If you tell me which is not given, then I will tell you why it is not given, guys. Okay, I got two answers, only two answers, guys. Me, Ajay Kumar, Meera, Rohan, TK, Prakhar, Kashif, Shubhajit, Ajay, Rohan, all of you, please try to answer. I got only three answers, guys. Why are you not answering? I don't know. Out of the three answers, only one student has answered it correctly, and the answer is vitamin A is not given. Vitamin A is not given. Now the question comes, why is vitamin A not given? So everybody, vitamin A is known as beta carotene. I hope you remember. Yes, vitamin A is given as beta carotene, and if you have read your pathologies, beta carotene increased levels promote or increase the risk, promote the risk of lung carcinoma in smokers. So we know that beta carotene is an antioxidant. It may help us in the treatment of ARMD, but we also know that if we give beta carotene, then it can increase the levels of lung carcinoma, and the patient is a smoker. We already know that. So we don't want to give vitamin A. Okay, everybody. This was told to us by a study called as AREDS2. AREDS2 study. So that's the study. Okay, AREDS2 study. So we are giving vitamin C. We are giving vitamin E. Please do remember, but we don't give vitamin A. Vitamin C is given 500 milligram. All these doses are fixed by this AREDS2 study, and we give 400 international units of vitamin E. Plus we give zinc and copper. Again, I hope you know that zinc is an antioxidant, and copper is given to prevent the toxicity of zinc. Okay, everybody. If zinc increases level, it can cause zinc toxicity. So copper, chelate zinc, and copper is given to prevent the toxicity of zinc. Okay, so zinc is given as zinc and copper. Again, I hope you know that zinc is an antioxidant, and copper is given to prevent the toxicity of zinc. Okay, everybody. If zinc increases level, it can cause zinc toxicity. So copper, chelate zinc, and copper is given to prevent the toxicity of zinc. Okay, so zinc is given as 80 milligram, and copper is given as 2 milligram, plus lutein and zeaxanthin. Lutein and zeaxanthin are basically replacements of beta carotene. They are naturally occurring carotenoids. So if you try to understand, we are actually giving vitamin A, but in a natural form, which does not increase the risk of lung carcinoma. So we are giving substances like beta carotene, which are lutein and zeaxanthin. Now, what is the dosage? So 10 milligram is lutein, and 2 milligram again is zeaxanthin. Okay, everybody. So that's your antioxidant treatment for dry ARMD to prevent the progression from dry to wet ARMD. I hope we are clear here. There's no confusion in this. Please remember the name of the study. Sometimes aims people do mention the name of the study to ask you a question. So just the famous studies, I keep telling you the important studies as always. Okay, guys, done. Now the question comes: do we do the treatment in all cases of ARMD? Okay, do we do the treatment in all cases of ARMD? The answer is no. Okay, treatment of ARMD is done. Treatment for ARMD is done only if treatment of for dry ARMD. Sorry, my mistake. Treatment for dry ARMD is done only if greater than equal to one of the following. Greater than equal to one of the following: one large drusen. Secondly, multiple intermediate drusen. If you just noted down, the large drusen was greater than 125 micron. Small drusen was less than 63. So between 63 micron to 124 micron will become your intermediate. Okay, everybody. Then geographic atrophy, or last, if you already have wet ARMD in the other eye. So everybody, if your age is greater than 55 years, and if you have at least one large drusen, or if you have multiple intermediate drusens, if you have geographic atrophy occurring in any part of the retina, or if you have wet AMD in the other eye, in all these cases, we will have to give antioxidants for you, everybody. Okay, everybody, but if you only have hard drusen, that is a small drusen, less than 63 micron, then we will not give you antioxidants. If your age is not 55, if you have just started 50, 51, then again, we will not give you antioxidant treatment for dry hair. Okay, everybody, done. I hope there's no confusion here. That's all about dry AMD. Now I'll put you more to wet AMD. In wet AMD, there were two signs, everybody. What were the two signs, everybody? What were the two signs of wet AMD? What were the two signs of wet AMD, everybody? Wet AMD, number one, PED. Full form of PED was pigment epithelial detachment. Pigment epithelial detachment. So again, I'll just simply try to tell you this, everybody. Again, this is your diagram. I'm not going into the detail of the pathogenesis. I'm just trying to explain you through common sense, everybody. So what is this, everybody? Again, neurosensory retina. This is your retinal pigment epithelium, and this is your Brooks membrane. These are your green colored drusens. When these drusens will become large, they will push the pigment epithelium up. Yes, they will push the pigment epithelium. They will push the pigment epithelium. When they push the pigment epithelium, the whole retina along with the pigment epithelium will detach. The whole retina along with the pigment epithelium will detach. Just to explain to you, I'll bring up a photograph. I hope you have revised your investigations of the retina, which I had told you in the first class day before yesterday, guys. Okay, so let's see this image, everybody. What do we see in this image, everybody? We see that this is an image of the OCT. Yes, this is an OCT image. Okay, everybody, this is an OCT image. In OCT image, we see that in this part, the whole retina is normal. But in this part, what do we see? Starting from the innermost layer to the red layer. What was the outermost red layer, everybody? I had told you that to see an OCT, the outermost red layer has to be RPE. So we see that along with the neurosensory retina, even the retinal pigment epithelium has been detached. So I can say all 10 layers of retina are detached. And when such a thing occurs, we start calling it PED, pigment epithelial detachment. I hope there is no confusion to this. So there here would have been your drusens, everybody, and those drusens would have been pushing this up, and that is what has led to the epithelial detachment. Then everybody, do we understand this OCT photograph? Everybody, do we understand this OCT photograph? Okay. Only 3 of you understand this OCT photograph. Again, it is somewhere telling me that either I don't know whether you are watching my previous sessions or not. It becomes difficult after that, guys. So please, I request you after this session, if you have not watched any of the previous sessions, please do try and go back and watch the previous sessions, at least of retina, so it becomes easier for us to understand. Or if you still don't understand, just please ask me, explain again. I will do that, guys. Okay, everybody done. So that's your first sign, and that is PED. Now, what is the next sign? The important sign, everybody. The next sign is CNV. The full form of CNV is choroidal neovascularization. Choroidal neovascularization, CNV. To explain you this, I have again the simple diagram that I've been drawing. This is your neurosensory retina. This is your retinal pigment epithelium. This is your subretinal space, and then this is your choroid with your Brooks membrane, and then all these blood vessels. Okay, everybody. What has occurred now, everybody? The drusens have already destroyed your retinal pigment epithelium. They have caused geographic atrophy. Similarly, the drusens will also destroy your Brooks membrane. I hope you understand this. Yes, because the drusens are present, and then this is your choroid with your. Explaining this, I have again the simple diagram that I've been drawing. This is your neurosensory retina. This is your retinal pigment epithelium. This is your subretinal space, and then this is your choroid with your Brooks membrane, and then all these blood vessels. Okay, everybody. What has occurred now, everybody? The drusens have already destroyed your retinal pigment epithelium. They have caused geographic atrophy. Similarly, the drusens will also destroy your Brooks membrane. I hope you understand this. Yes, because the drusens were present here, everybody. Because the drusens were present here, they put pressure on the pigment epithelium and destroyed it, and on the Brooks membrane and destroyed it. What has this given, everybody? This has given now a rasta or a way for these blood vessels to grow some neo vessels upwards. So these neo vessels will now grow upwards into which space, everybody? Which space will they grow in now, everybody? Subretinal space. Now I hope you know that neo vessels are leaky vessels. Neo vessels are called as leaky vessels. Why are they called as leaky vessels? Because they don't have the endothelium properly formed, collect in subretinal space. So I can call it subretinal hemorrhage. Now, slowly, the hemorrhage which has occurred will start getting absorbed. It will start getting absorbed by the formation of a membrane. Yes or no? Fibrovascular membrane. So what is forming, everybody, basically at the retina? Subretinal fibrovascular membrane. Am I clear, everybody? So that's what I'm trying to right now call you choroidal neovascularization. What occurs, everybody, in choroidal neovascularization? Due to disturbance of vascular membrane. So what is forming, everybody, basically will start getting absorbed. It will start getting absorbed by the formation of so I can call it subretinal hemorrhage. Now, slowly, the hemorrhage which has occurred will start getting absorbed. It will start getting absorbed by the formation of a membrane. Yes or no? Fibrovascular membrane. So what is forming, everybody, basically at the retina? Subretinal fibrovascular membrane. Am I clear, everybody? So that's what I'm trying to right now call you choroidal neovascularization. What occurs, everybody, in choroidal neovascularization? Due to disturbance of RPE, and I can say, sorry, I'll just write it, RPE and Brooks membrane. Okay, neo vessels grow in subretinal space. I hope you understand. And because neo vessels are leaky vessels, they cause subretinal hemorrhage. Then this subretinal hemorrhage will organize or will get absorbed by formation of fibrovascular membrane. And then this fibrovascular membrane gets to be known as choroidal neovascular membrane. This gets to be known as choroidal neovascular membrane. I hope none of you have a problem with this. Gets to be known as choroidal neovascular membrane. Right, guys? Am I clear to everybody? Am I clear to everybody? CNVM. And the CNVM is the most common cause of loss of vision in ARMD. Please remember this. Please understand this. Okay, everybody. So again, sir, because of the disruption of the RPE and Brooks membrane, the choroidal vessels grew into the subretinal space because they are neo vessels, leaky vessels. Because hemorrhage, subretinal hemorrhage, then the hemorrhage gets absorbed by the formation of a fibrovascular membrane, which is known as CNVM. But now because the membrane has formed, it will interfere with vision, and that is why CNVM is the most common cause of visual loss. Am I clear, everybody? Again here, yes. I know these are new concepts probably because we have not read them, but because these are important to be able to learn this and understand this. Okay. Now, CNVM. The CNVM that I have written is basically of two types. The two types of CNVM are called as, one is called as classical CNVM and the other is called as occult CNVM. Classical CNVM, occult CNVM. Okay, everybody. Now, classical CNVM is found in the subretinal space. Classical CNVM in subretinal space, just like I explained to you. But the occult CNVM is slightly different. Instead of forming in the subretinal space, it is formed in the sub-RPE space. It is formed in the sub-RPE space. If you try to understand, everybody, this is your subretinal space. So this is where your classical CNVM is formed, but occult CNVM is formed here, everybody. So this is your sub-RPE space. So classical CNVM, occult CNVM. Do you understand this? Classical CNVM, occult CNVM. Am I clear, everybody here? Am I clear, everybody? Subretinal space is present between neurosensory retina and pigment epithelium. Below the retinal pigment epithelium, the space which is present will be called as subretinal pigment epithelium space. That is the basic difference between classical CNVM and occult CNVM. Now, the question that they ask you is, what is the investigation of choice for classical CNVM? And similarly, what is the investigation of choice for occult CNVM? I will ask all of you to type in the chat box. If your chat box is active, if you're not a trial student, guys, what is the investigation of choice for classical CNVM? If you will use your brain side, taught you all the investigations of ophthalmoscopy, OCT, FFA, B-scan, ICGA, ERG, EOG, photo stress test, AMSURS, I taught you everything. What should be investigation of choice? I am giving you a clue. See the name, choroidal neovascular. Or focus on this word, V for vascular, V for vascular. That whatever this problem is, it is actually at last vascular. You are trying to see the vascular network. What should be the investigation of choice? Don't let me tell you the answer, everybody. Think about it and try to write the answer yourself. It is a vascular problem, so what should be the investigation of choice? It is a vascular problem. What should be the investigation of choice? Okay, guys, none of you seem to be replying. None of you seem to be in the mood to interact. And what the answer is. For classical CNVM, the investigation of choice is FFA. Now, what about occult CNVM? If you try to understand, occult CNVM is below the retina. It is below the retina. So we can say it is actually near to the choroid. If you again remember the investigation below the retina, so we can say it is actually near to the choroid. If you again remember the investigations I told you, for all the choroidal pathologies, we don't prefer FFA. Instead, we prefer ICGA, indocyanine green angiography. And that is the linking of my first session on retina to today's class. I would have hoped that you would have done it yourself, but alas, you were not able to do it. So I have done it for you. And that's your CNVM, guys. Okay, so these are the two signs of wet ARMD. Now let's move on to the treatment of wet ARMD. Treatment of wet ARMD. So again, I will ask you, what is the treatment of choice? What is the treatment of choice? Again, I will ask you to focus on one word. The main problem is neovascular. Neovascular. That means neovascularization is occurring. If neovascularization is occurring, everybody, we know through pathology that neovascularization occurs due to a factor called as VEGF. So that makes my treatment of choice anti-VEGF drugs. I somewhere know that because neovascularization is occurring, there would be some VEGF. So let's give anti-VEGF drugs. So now, what are the names of the anti-VEGF drugs, everybody? What are the names of the anti-VEGF drugs? So the names are ranibizumab. Then the name is bevacizumab, aflibercept, and lastly, very important name, which is a new drug. This is a new drug which has been recently approved some months back. It is brolucizumab. Brolucizumab. Okay, everybody. So brolucizumab. This is one of the newest drugs that has been approved. And guys, I hope I'm clear here. I hope there is no confusion here. Now, out of these, which of the following is the best drug if they ask you? So ranibizumab is the best anti-VEGF. Okay. Ranibizumab is the best anti-VEGF. What is its dose, everybody? So its dose is 0.5 milligram per or in 0.05 ml. So we inject 0.05 ml of the drug, which contains 0.5 milligram of the dosage or the concentration, everybody. Okay, everybody. Now, bevacizumab is actually not FDA approved. Its dosage is 1.25 milligram per 0.05 ml. The dosage of aflibercept is 2 milligram. The dosage of aflibercept is 2 milligram. Okay, everybody, done. That's the treatment of choice. I hope when I ask you the question, where will you give the anti-VEGF drugs? Where will you give the anti-VEGF drugs? That means, will you give them intravitreally? Will you give them intravenous? Will you give them oral? I hope it is very clear. It should be very clear that the pathology is in the retina, guys. So because the pathology or the pathogenesis is in the retina, I need to give the drug near the retina. Near the retina, the easiest route of administration is intravitreal. As I tried to explain previously in some of the diseases, that whenever the pathology is in the posterior segment of the eye, we have the best route to give intravitreal. Please remember, posterior segment pathology, give a drug intravitreally if possible. Posterior segment is equal to intravitreal drug administration. That's your treatment of choice. Now, apart from anti-VEGF drugs, what is the second treatment we need to do? The second treatment, guys, that we need to do, or we can do rather, is called as PDT. The full form of PDT is photodynamic therapy. Photodynamic therapy. If you remember from the last lecture, I told you photodynamic therapy is also the treatment for a disease called as CSR, central serous retinopathy. Okay, so we have used PDT there also. Now the question comes, what is PDT and which drug do we use in PDT? So everybody, from the name it should be very clear, photodynamic. That we are giving a drug and that drug is changing some kind of a form. So which drug is used in photodynamic therapy? The drug is called as verteporfin. If your biochemistry is good, you will remember, or you should be able to understand from this name, porphin. Porphin is telling us porphyrin ring molecule. Porphyrin ring molecules are photosensitizers. Okay, everybody. So we are basically giving a porphyrin ring molecule, verteporfin. The dosage is 6 milligram per meter square. Okay, so the dosage is 6 milligram per meter square of the area of the total area that we are giving it. And then we illuminate. We first give the drug, then we illuminate by light The wavelength of light is 692 nanometers. Okay, everybody. We illuminate by 692 nanometers. This will polymerize, this will change form, and this will lead to the treatment. Okay, everybody. That's the simple thing that you want to understand. This question has not been asked in terms of which drug is using PDT. I don't think they will go deeper than this, so that is what I'm restricting at PDT. The drug is vertiporfin and it is used to illuminate light. Now, what are the indications of PDT? Indications of PDT, as I have just now tried to explain to you, the indication of PDT is number 1, choroidal neovascular membrane. Number 2, I hope you understand this, CSR. Number 3, pathological myopia. Please remember, for myopia pathological, we can also use PDT. And another important indication is ocular histoplasmosis syndrome, POHS, presumed ocular histoplasmosis syndrome. Presumed ocular histoplasmosis syndrome. So this can be a straight question to all of you, everybody. Which of the following diseases can we use the treatment called photodynamic therapy? So these are the 4 things. CNVM, I hope you understand, choroidal neovascular membrane, what we are studying. CSR, we have already studied. Myopia, you know, and POHS, presumed ocular histoplasmosis syndrome. So from my side, guys, that's it about ARMD as a topic. I hope you have been able to understand it, though a lot of you are not replying, a lot of you are quiet, so I don't know whether you have been able to understand it, but I do hope you have understood it. Please just remember it simply that ARMD, D for dry and wet, D for dry, D for drusen, and drusen is something separate from exudates. In dry stage, our treatment is antioxidants. Okay, everybody, D for dry, D for drusen, D for antioxidants, you can say. Okay, everybody, then wet stage is called wet stage because there is some kind of bleeding, hemorrhage. What is hemorrhage? Choroidal neovascular membrane causing subretinal hemorrhage. I hope you understand this. Now the word becomes neovascular because neovascularization is occurring. That is why the treatment becomes anti-VEGF drugs. So if you try to revise it in your mind, it can become like a story, and you can revise it very quickly amongst your revision strategies, guys, right? And that's all about macular disorders from my side. So we have finished with macular disorders. We had done it previously in the last session, and today we have done our ARMD. So now I start with the next group of disorders, everybody. So the next group of disorders that we start today with, as was mentioned as the topic of the session today, is fundus dystrophies. Fundus dystrophies. Okay, everybody. So the next topic is fundus dystrophies. Now, everybody, fundus dystrophies. So we have done 2 group of disorders till now. One was the tumor, retinal prosthesis, and now is the macular group of disorder. Now this is the third group of disorder. This disorder is fundus dystrophies. When I say dystrophy, what do we understand? Dystrophy basically means degeneration. Yes or no? When we don't know the cause of the degeneration, we call it a dystrophy. So this is basically a degeneration without a known cause. This dystrophy, even though it is termed fundus dystrophy, actually these dystrophies affect the retinal pigment epithelium Brooks membrane junction. Okay, so these are, I can say, degenerations affecting photoreceptor, RPE, and choriocapillaris. Brooks membrane can say capillaries, choriocapillaris. This is the site of the fundus that they are mainly affecting, the retinochoroidal junction, photoreceptor, RPE, the outermost 2 layers, and then choroidal capillaries or choriocapillaris as we call it. Okay, everybody. Now, so basically, if we see the fundus dystrophies, even though they are degenerating the whole of the fundus, we are interested in this word. What is the word? Photoreceptor. That dystrophies of the fundus are at last degenerating my rods and cones. So we say these dystrophies can either be rod cell degenerations or cone cell degenerations. Because this can either be rod cell or cone cell degenerations, first of all, we should know a little basic about rod cell and cone cells. Now, I will just simply write rod cells. Where are rod cells located? Rod cells are located in the periphery, or I can say perifoveal, around the fovea, not at the fovea. Whereas where are cone cells located? Cone cells are located in the center, I will say, or I will say at the fovea. Rod cells are responsible for which vision, everybody? Do rod cells give us color vision or black and white vision? They give us black and white vision. So we call it basically night vision, yes? Or night vision is also called as scotopic vision. Cone cells, everybody knows, gives us color vision. Okay, everybody? Cones are responsible for color. And color vision is also known as photopic vision. Am I clear? Basics about rods and cones. Rods are located in the periphery, they give us night vision. Cones are located in the center, they give us color vision. Okay, everybody? So if there is a lesion of rod cell, if there is a lesion of the rod cell, what will occur, everybody? What will occur? First of all, what will occur is peripheral loss of vision. Am I right, everybody? Because they are giving us peripheral vision, it will lead to peripheral loss of vision. I hope there is no confusion in this simple fact. And because they were giving us night vision, it will lead to night blindness. Night blindness is famously known as nyctalopia. Now, if it was a cone lesion, then it would have caused what? Let's see. Because they're present in the center, there would have been central loss of vision. And because they give us color vision, I would have become color blind or day blind. And day blindness is known as hamaralopia. Sorry for running out of space, but please, I hope you understand it. Now, the only thing you may not understand, which I've already explained before also, is why is color blindness and day blindness the same. So I explained to you this in cataract, I hope. Colors, Vibgyor, Vibgyor. Day is made up of sunlight. Sunlight is Vibgyor. So when you can't see colors, you can't see sunlight. When you can't see sunlight, you basically can't see in the day. Am I clear to everybody? So color blindness and day blindness become the same. And nyctalopia is called as night blindness, whereas hamaralopia is cone cells. Also, because it is mentioned somewhere or asked somewhere, rod cells are more than cone cells. Rod cells are 120 million. Whereas cone cells are only 6.5 million. Okay, so almost 20 times, everybody. Rod cells are almost 20 times more than cone cells. Okay, so I got a thumbs up from 2 or 3 students, everybody. I hope the rest of you are also understanding it. So basic difference between rod cells and cone cells, everybody. Okay, now there are 2 important words here which obviously you understand can be asked as MCQs. Nyctalopia, what are the causes? Hamaralopia, what are the causes? Okay, so now I'll be bringing up an image for causes of nyctalopia and hamaralopia. You can understand this, see this, and learn this, please. Okay, these are straight questions. All of the following are causes of hamaralopia, except all of the causes of nyctalopia, except everybody. So let's first see nyctalopia. The mnemonic is OMG. Oh my God, OMG, crap, CRAP into 2. Okay. So O for, I will just complete this disease with you in a little while, Oguchi disease. M for myopia, only in very high cases of myopia. G for gyrate atrophy. C for, again I will cover this disease, congenital stationary night blindness from the name itself. C for cortical cataract. You should remember this cortical cataract. Everybody, I hope you remember this. Where is cortical cataract present? Cortical cataract is present in the periphery of the lens. Because it is present in the periphery of the lens, at the night when pupil dilates, light is not able to go inside, and it causes loss of vision in dim light or night light. Retinal detachment. Retinitis pigmentosa. I will just post LASIK. So after LASIK also there occurs slight problem in night vision. Okay, everybody? So these are the important causes of nyctalopia. Please remember OMG crap. O for which disease, M for myopia, G for keratophy, C for cortical cataract, C for congenital stationary night blindness, R for retinitis pigmentosa, R for retinal detachment, A for A vitamin deficiency, A for albicum tetrus fundus, P for phenothiazines, and P for post-refractive surgery. Please do just revise it. Okay. Now next, everybody, we move on to the mnemonic for hemarolopia or day blindness. Okay. I hope you remember again, hemarolopia is day blindness. So for day blindness, the mnemonic is CAT, C-A-T, C3A3 T1. C for cone dystrophy. Very simple, everybody. If cone cells are dystrophic, obviously I will not have color vision and division. Central cataract, again, like I explained you, if the cataract is central, in the daytime the light will not be able to go inside and it will lead to day blindness. Then Cohen syndrome. Then A for achromatopsia. Achromatopsia, we have covered in neurophthalmology. Achromatopsia means no color vision. The definition itself is no. Fundus dystrophies affect the photoreceptors. Because we say fundus dystrophies affect the photoreceptors, they either affect the rod cells more or they affect the cone cells more. If they affect the rod cells more, they will cause nyctalopia. If they affect the cone cells more, they will cause hemarolopia. So by knowing which cells are being more affected for a specific dystrophy, we know the presentation and the symptom in a lot of ways. Okay, everybody? So that is what we are beginning with now, fundus dystrophies. The first fundus dystrophy that we will discuss is known as a very important dystrophy. I hope you have heard this name before, everybody. Retinitis pigmentosa. So the first fundus dystrophy that we are covering today is called as retinitis pigmentosa. Now, retinitis pigmentosa is the most common hereditary fundus dystrophy. This is the most common hereditary fundus dystrophy. So it is most common. First question. Second question is, it is hereditary. If it is hereditary, I am inheriting it. So my question to you will be, everybody, what is the most common mode of inheritance? What is the most common mode of inheritance? Option A, autosomal dominant. Option B, autosomal recessive. Option C, X-linked recessive. Option D, X-linked dominant. Anybody? I am starting a poll. Let's see everybody who can answer this. What is the most common mode? Monica and Sindhuja have got it right till now. Anybody else? Okay, nobody else is trying it, it seems. Okay, one more student has tried it but has got it wrong. Okay, guys, so all of the three students I have named, Subhajit, Donika, and Sindhuja, you have got it right, and I think you have answered what, everybody? You have answered autosomal recessive. Okay, everybody. So the most common mode of inheritance is autosomal recessive. The most common mode of inheritance is autosomal recessive. I'll just quickly write it down. Autosomal recessive. But can retinitis pigmentosa be autosomal dominant? Yes, it can also be autosomal dominant. And whenever it is autosomal dominant, we say it will have the best prognosis. I hope you understand the meaning of prognosis. Prognosis means outcome. And in the case of eye, it means visual outcome. So if a patient has retinitis pigmentosa, which is inherited autosomal dominant, his visual outcome will always have a good outcome or good prognosis. But if it is X-linked recessive, it can be X-linked recessive also. But if it is X-linked recessive, we say the retinitis pigmentosa cases have the worst prognosis. Am I correct, everybody? So the worst outcome or the worst prognosis will be in cases of X-linked recessive retinitis pigmentosa. These are three questions which are commonly asked. Students somehow keep on mistaking this question. In a lot of places, I've seen that the most common mode of inheritance is given as autosomal dominant. Please do remember it is autosomal recessive. It can be autosomal dominant, but the most common is autosomal recessive. Then everybody, there is no confusion. I hope everybody. Now after we have done the inheritance, let's see the symptoms of retinitis pigmentosa. Okay, so symptoms of retinitis pigmentosa. Now, for the symptoms, what do you want to know? As I've explained to you, for the symptoms, we only want to know whether it is a rod dystrophy or whether it is a cone dystrophy. Am I correct, everybody? We want to know rod dystrophy or cone dystrophy. So I say it is a rod cone dystrophy. It is a rod cone dystrophy. Now you must be thinking, sir said either rod or cone. Now sir has written rod cone dystrophy. What a joke, guys. So see, whenever a dystrophy occurs, it will usually affect both the cells, rod cells as well as cone cells. But the presentation is actually based on which cells are affected first and which cells are affected more. So when I write rod cone, it is basically trying to tell me that the earliest cells affected or degenerated are rod cells. It is mostly affecting the periphery and the rod cells. Okay, everybody? So as soon as I know it is a rod cone dystrophy, then I think about what will be the symptom. So the symptom will be rod cell problem. And as we have just now discussed, rod cell problem is what, everybody? Nyctalopia or night blindness. I hope there is no confusion in this. So the symptom is nyctalopia or night blindness. Am I correct? Now, what is the visual field defect? Visual field defect. Again, I hope you understand that I told you the basics because of these rod cells are present in the periphery. So which vision will be lost first? First, everybody, peripheral. Okay, everybody? Then I think about what will be the symptom. So the symptom will be rod cell problem. And as we have just now discussed, rod cell problem is what, everybody? Nyctalopia or night blindness. I hope there is no confusion in this. So the symptom is nyctalopia or night blindness. Am I correct? Now, what is the visual field defect? Visual field defect. Again, I hope you understand that I told you the basics because of these rod cells are present in the periphery. So which vision will be lost first? First, everybody, peripheral. Okay, everybody? So first we have mid-peripheral scotomas. Mid-peripheral scotomas. Mid-peripheral, not absolute periphery, mid-periphery or mid-peripheral scotomas. Then this mid-peripheral scotomas, they will keep on becoming larger. When they keep on becoming larger, try to understand it. Right now the patient is telling me, sir, here I can see all this center I can see. I can't see this periphery. I can't see this periphery. Okay, everybody? Now in this mid-peripheral scotoma, first of all, superior part is affected. and then it is followed by inferior part. So first of all, the patient is telling me, sir, I can see here, but the superior part of the periphery I can't see. Then he says, sir, first of all, only the superior part I can see. Now I can't see the inferior part. So now he will tell me, sir, I can see the center, but I can't see this area. Everybody see my hand movement. So basically, the patient is drawing a circle in the air, telling me, sir, this periphery I can't see. Okay, everybody. Now, whenever the patient draws this circle, the patient can basically, or patient is trying to say, sir, my scotoma has now become which shape? My scotoma has now become ring shaped. I hope you understand this. Yes, it has become a circular scotoma. It has become a ring shaped scotoma. Okay, or some people also call it donut scotoma. Some people also call it donut scotoma. I hope you understand. There is no confusion in this. Okay, ring scotoma or donut. If you have eaten a donut, if you haven't eaten a donut, don't worry. This must have been described by a Western person. Okay, if an Indian would have described it, he would have said it is vada scotoma. I hope you understand. Vada sambar. So vada also looks like a donut. Yes. So in the center you can see, in the periphery you can't see. Okay, so donut scotoma, ring scotoma, or to remember you can call it vada scotoma. Now, when this scotoma will progress, what will happen, everybody? It looks as if everybody, somebody has kept a tube in front of me, so I can only see the center as if I'm looking through a tube. Okay, everybody, and the rest of the vision I have lost. So that's why the patient now starts describing it as tubular vision, or which can also be called as tunnel vision. Again, I hope you don't have a problem understanding this tunnel vision, everybody. If you're going in a train and suddenly a tunnel comes, everybody, you can't see any of the periphery surroundings, you can only see the tunnel center. Am I clear, everybody? Yes, sir. Are we clear, sir? Yes, sir. So what we're trying to understand here is that the mid-peripheral scotoma, ring scotoma, donut scotoma, tunnel vision, and tubular vision, all these are actually same names. These are just different descriptions. In all these, what we understand is that the peripheral vision is being lost, but the central vision is being retained. And peripheral vision is being lost due to this cell. What is this cell, everybody? Rod cell. I hope I'm very clear. I hope I'm absolutely clear about this. Okay, everybody done? And that's all about the symptomatic and the visual field effect here now. Okay, guys, now let's move on to the signs, please. So what are now the signs? So it is a triad of signs. We say there are three signs. The first sign is arteriolar attenuation. Arteriolar attenuation. Arterioles, I hope you understand. Attenuation. What do you mean by attenuate? Attenuate means to close. So basically, arterioles are being constricted and they are closing. Arteriolar attenuation. The second important sign is waxy, pale optic disc. Anybody can think of why the optic disc is waxy and pale? The answer is in neuroophthalmology. I've already done neuroophthalmology. I've already done 6 to 7 hours of neuroophthalmology with you guys. Why is the optic disc waxy and pale? If you can remember, everybody. If anybody can remember, anybody can type in the comment. Why is the optic disc waxy and pale? Okay, I don't know if you can. I don't know. Okay, so if you've seen my neuroophthalmology videos, we have taught optic atrophy. Optic atrophy is of 3 types: primary, secondary, consecutive. Consecutive optic atrophy occurs due to all retinal diseases, in which I explained that retinitis pigmentosa, which is a retinal disease, can cause consecutive optic atrophy. And whenever consecutive optic atrophy occurs, the optic disc becomes waxy and pale. So due to consecutive optic atrophy. Then number 3, the diagnostic sign, bony spicule pigmentation. So third sign is actually diagnostic in a photograph or when you're examining the patient. Okay, everybody. So bony spicule pigmentation. Am I clear, everybody? No confusion. The name of the disease is pigmentosa. Now let me show you the image. I hope when you see the image, you will be able to very easily understand this. Again, I hope you don't jump onto the diagnosis. You start to see it stepwise. The first step I always have told you to see in a photograph is see the optic disc, find the optic disc. This is my optic disc, everybody, present at the bottom. That means this image that has been given is not of the center of the retina. If it would have been of the center of the retina, my optic disc would have been seen here. So I see that this is an image of the periphery first. Now in the periphery, I know that scattered throughout the periphery are some pigments in bony corpuscle shapes. Can I say this, everybody? Bony corpuscles. So this is bony spicule pigmentation. Also, if I try to note carefully, you see this, everybody? See this arteriole and artery, everybody? Can you see that this arteriole or artery has been completely attenuated? Yes or no? Yes. So we can also see arteriolar attenuation along with bony spicule pigmentation, which makes it a case of retinitis pigmentosa. I know the bony spicule pigmentation is the most easily visible. So for your exams, please just remember bony spicule pigmentation for a photograph. Whenever you get such a photograph with bony spicular, corpuscular pigmentation scattered all around, just answer retinitis pigmentosa without a doubt. I hope I'm clear about the photograph. I hope there is no confusion. Okay, everybody. So these are the 3 signs of retinitis pigmentosa. Now, once we are over with the signs, guys, okay, let me just tell you one more sign actually. So I'll just put a star here and I will write in X-linked recessive retinitis pigmentosa, tapetal reflex. Tapetal reflex. Tapetal reflex. That is a golden metallic reflex. A golden metallic reflex is seen at macula. So this sign is specific to X-linked recessive type of retinitis pigmentosa. When you try to examine the macula, it shines with golden kind of metallic reflex sheen. Okay, everybody? And that is specific to this condition. Okay, am I clear, everybody? Done? Just remember this also. Now, I'll ask you next point after the signs. What is the investigation of choice? What is the investigation of choice? Anybody would like to tell me? Again, think about it. OCT, FFA, B scan, FFA, B scan, ERG, EOG, ERG, EOG. Think about it. ERG, electroretinography. If you remember electroretinography had 3 waves, A wave, B wave, and C wave. A wave was a function of photoreceptors, rod cells, and bone cells. Now, rod cells and bone cells are getting dystrophy, so obviously the ERG will become subnormal. Am I clear? And that is why the investigation of the choice becomes ERG. Photoreceptors produce the visual impulse. Now, there is no visual impulse, so there is no electricity, and then later on even the center. But there have been recent advances in the outside India. Okay, everybody? So outside India, that means the Western world basically. There have been some recent advances. Number 1, there is something called as Argus 2 retinal prosthesis. Argus 2 retinal prosthesis. Okay, everybody. What are we doing? Focus on the word prosthesis. Prosthesis means artificial. We know our retina is not functional because rod cells and cone cells are destroyed. So we are basically implanting an artificial or prosthetic retina. Am I clear, everybody? This only restores central 20-degree of vision. This restores not the complete vision, but only central 20-degree of vision. But that is enough, guys. If you can see central 20-degree, at least you will be able to carry out your day-to-day life, guys. Am I clear, everybody? And the second is a drug. The drug is known as voretigene niparvovec. Voretigene niparvovec. Very easy to remember, everybody, if you understand Hindi. Wo wala. रेटिनाइटिस पिगमेंटोसा का जीन। ओके एवरीबॉडी, वो वाला रेटिनाइटिस पिगमेंटोसा का जीन खराब था, उसको ठीक कर रहे हैं। वो रेटिजीन निपार्वोवेक, वो रेटिजीन निपार्वोवेक, एम आई क्लियर एवरीबॉडी ना? वो वाला जीन, कौन से वाला जीन? ओके, यूज्ड इफ बाय अलीलिक RPE65 gene mutation. So if retinitis pigmentosa has been caused due to RPE65 gene mutation, we are saying वो वाला retinitis pigmentosa का जीन खराब है, उसको ठीक करते हैं। ड्रग कौन सा दिया? वो वाला retinitis pigmentosa, वो रेटिजीन निपार्वोवेक, and that is the drug we are giving, वो रेटिजीन। Okay, this is injected subretinally, this is injected subretinally. So basically, this is a gene therapy, guys. Okay, this is a gene therapy. Both these treatments are very costly. That is why they have not been able to penetrate India as of now. Maybe in the future, maybe 5, 10 years, 20 years down the line, maybe they come to India also. Though there is no other treatment, so these are the best options we have right now, guys. That's all. Okay, everybody done, and that's the treatment options. Please remember, India still has no treatment. Please remember, India still has no treatment. Now, after we've done the treatment, we've discussed the treatment. Let's move on to a very important question that they ask you: what are the systemic associations of retinitis pigmentosa? Now, the systemic associations of retinitis pigmentosa, number one, most common. At a lot of places, it is given as Usher syndrome, which is absolutely wrong. The most common is Lawrence-Moon-Bidal or Biddle syndrome. Lawrence-Moon-Biddle syndrome. What is Lawrence-Moon-Biddle syndrome? Retinitis pigmentosa plus obesity plus mental retardation plus polydactyly. Okay, plus polydactyly. So this is what occurs in Lawrence-Moon-Biddle syndrome. Okay, everybody, what occurs in Lawrence-Moon-Biddle syndrome. I hope you don't have any confusion again, everybody. This should be very absolutely simply clear to all of you. Right now, next important investigation, as I just mentioned, the name is Usher syndrome. This is not the most common. Please, this is not the most common. This is retinitis pigmentosa plus deafness. Number 3, Refsum's disease. Refsum's disease. Refsum's disease is RP plus cerebellar ataxia. And then one condition which is related to pathology, if you know it, A beta lipoproteinemia. A beta lipoproteinemia. A beta lipoproteinemia. Okay, so this is retinitis pigmentosa plus acanthocytes. Plus acanthocytes. Acanthocytes are also known as spur cells. I hope you understand this. So this is a blood abnormality basically. Along with retinitis pigmentosa, there is a blood abnormality, acanthocytes or spur cells. Then everybody, these are some of the systemic associations of case of retinitis pigmentosa. Nothing more to discuss here. I hope retinitis pigmentosa is a very simple disease. If you want to remember retinitis pigmentosa, just remember 2 words. Number 1, pigmentosa. Pigmentosa means pigmentation. Remember the photograph. R for retinitis, R for rod cell. Rod cell. Rod cell means vision loss, peripheral vision. As soon as you remember the peripheral vision loss, move your hand like this: wings, scotoma, donut, scotoma, or tubular vision. Yes. Then rod cell. Rod cell for night blindness, nyctalopia. Because rod cells are getting dystrophy, rod cells will not be able to generate the visual potential. So the investigation of choice is ERG, electroretinography. Action potential of retina is not generated at all. So it is either subnormal or flat. Am I clear to everybody? Then just remember there is no treatment in India and some systemic associations along with it. So along with R and pigmentosa, you can remember the whole retinitis pigmentosa. Now, let's move on to the second disease now. The second fundus dystrophy is known as Best's macular dystrophy. Best's macular dystrophy. So now again, I'll proceed in the same way. What is the mode of inheritance? So the mode of inheritance in this case is autosomal dominant. Mode of inheritance is autosomal dominant. The gene is called as VMD2. The gene is VMD2, which encodes bestrophin protein. I hope you understand from this that the name of the disease is Best's because there is problem in translation and transcription of bestrophin protein. Am I clear, everybody? Best's does not mean it is the best quality of dystrophy. No, Best's is the name based on the protein. Okay. Now, what is the symptom? As soon as I ask you what is the symptom, I hope you will be able to use your brain and answer through this word. In the name, I've written everybody that it is macular dystrophy. Macula means somewhere fovea. Fovea or the center, it contains which cells? Cone cells. So through the use of the word macula, I know it is a cone dystrophy. If it is a cone dystrophy, what should be the symptom? The symptom should be hamara lopia. Yes or no? Again, I've explained to you cone dystrophy will cause color vision or day vision, and it is hamara lopia. Am I clear, everybody? No confusion here. Then, what are the signs? So, sir, sign number 1, there is deposition of lipofuscin. Deposition of lipofuscin pigment. Okay, everybody? Done? No confusion here. Simple. Till now, I hope everybody understands. Then, second important sign, which is the characteristic sign, is known as vitelliform lesions. Now, vitelliform means egg yolk like. Egg yolk, I hope everybody understands. Egg yolk is the yellow part of the egg, everybody. The yellow part of the egg has something called vitellin as a constituent in it, and that is why the name has become vitelliform lesion. Okay, everybody. Now, try to imagine the dystrophy is at the macula. Over the macula, you have a half fry cap. Half fry, you understand? Where you cook all the egg whites, but you don't disturb the egg yellow or the egg yolk. So over the macula, you have a half fry cap. So what will you see? You will see at the macula a round yellow colored lesion. Okay. But again, for seeing this image, I will first see the anatomy. This is my optic disc. From the optic disc, these are my blood vessels. Wherever my blood vessels goes, that is my temporal side. That means this is my macula. Macula is situated temporally. Now, over the macula, what do I see? I see an egg yolk. Do I see an egg yolk-like appearance, everybody? Yes or no? This yellow colored lesion, egg yolk-like appearance. And that makes it a disease of, or a photograph of, Best's dystrophy. Okay, thank you for understanding. Thank you for the thumbs up. Thank you. I hope you are getting into your heads. That's what is more important for me here. Am I clear, everybody? Done? Okay, guys. Now, the third sign, everybody, after vitelliform lesions, which is egg yolk-like, is known as pseudo hypopyon. pseudo hypopyon. So again, I discussed hypopyon I think twice already in my lectures. So what is hypopyon? Hypopyon is collection of pus in anterior chamber. But here pus is not collecting. This is not an infected lesion. There will be something which will collect in the anterior chamber, which will look like pus, but will actually not be pus. Okay, everybody. So we call this stage. Basically, if I try to explain to you, let's say there was the egg yolk. Now you have broken the egg yolk. So all the liquid out of the egg yolk has oozed, and from the retina it has now moved into the anterior chamber. So understand, vitally form egg yolk. You break the egg yolk, all the liquid oozes out, vitally eruptive, and goes and collects into the anterior chamber. So we start. So basically, if I try to explain to you, let's say there was the egg yolk. Now you have broken the egg yolk. So all the liquid out of the egg yolk has oozed, and from the retina it has now moved into the anterior chamber. So understand, vitally form egg yolk. You break the egg yolk, all the liquid oozes out, vitally eruptive, and goes and collects into the anterior chamber. So we start calling it pseudo hypopyon. Done, everybody? These are the three important signs of a case of Best dystrophy. Now that we're done with the symptoms and the signs, I hope we can do investigation. Please remember, is normal. But what is abnormal? EOG. EOG is abnormal. EOG thus is the investigation of choice. If you remember about EOG, EOG was measured through something called as Ardence ratio. Again, I've explained in my lecture on, I think day before yesterday when I was teaching on Sunday, if I remember, Ardence ratio. Normally, Ardence ratio is greater than 1.85, but in Best disease, Ardence ratio is less than 1.50. Okay. So because we have a characteristic Ardence ratio, we don't need any other investigation. This becomes the investigation of choice. Then everybody, normal ERG, abnormal EOG, and that's about Best macular dystrophy. That's all about Best macular dystrophy. Stargardt's disease. Okay, everybody. So Stargardt's disease. What is the mode of inheritance? Autosomal recessive. What is the name of the gene? ABCA4 gene. The name of the gene is ABCA4 gene. Okay. This is the most common macular dystrophy. This is the most common macular dystrophy. I again hope I don't have to explain again and again because this is the most common macula means cone cells. So this is a cone dystrophy. Cone dystrophy will lead to which loss of vision? Again, everybody central. Again, I don't think I have to go over it again and again. And because this cone color vision, day vision, so it will also cause hemaralopia or hamaralopia. Am I correct, everybody? Again and again I'm saying I've explained you this. I hope you understand this. If you don't, please just feel free to ask me and I will go through it all again. Now, what are the signs? This is where the beauty comes in. Signs are number one, fleck-shaped deposits. Fleck-shaped deposits. Okay, fleck. If you've seen flattened rice, which you call poha or chura or whatever you call it. Okay, so that is a fleck-shaped deposit, a flattened shape like this. Okay, fleck-shaped deposit. Then bronze beaten appearance at macula. We see a bronze beaten appearance at macula. Then number three, characteristically, we see something called as bull's eye maculopathy. Bull's eye maculopathy. Everybody, bull's eye maculopathy. Now, bull's eye maculopathy. Everybody. Bull's eye maculopathy is caused by one drug also. Anybody? Given the current scenario, can you remember the drug which causes bull's eye maculopathy? Very important, guys. Bull's eye maculopathy. Any drug which causes bull's eye maculopathy, guys. Any drug that you know of causes bull's eye maculopathy. Chloroquine, guys. Chloroquine causes bull's eye maculopathy. Now let's see this image, everybody. This is your optic disc. These are your blood vessels. This is your temporal side. That means this is your macula. Delineate them. Everybody, this is the first dark red circle I see outermost. Then this is the second circle I see light, and then this is the third circle. So number one, number two, number three. Can I see? So does this look like a dartboard to everybody? Yes or no? You understand dartboard? Dart. Yes. When you hit the center of the dartboard, you call it what everybody? Bullseye hit. Yes or no? If you guys hit the centermost point of the dartboard, you call it bullseye hit, and that is why this appearance gets the name bull's eye maculopathy. Over the macula, you have a bull's eye lesion. Can I see? So does this look like a dartboard to everybody? Yes or no? You understand dartboard? Dart. Yes. When you hit the center of the dartboard, you call it what everybody? Bullseye hit. Yes or no? If you guys hit the centermost point of the dartboard, you call it bullseye hit, and that is why this appearance gets the name bull's eye maculopathy. Over the macula, you have a bull's eye lesion. Am I correct, everybody? I just again remove it or erase it for you so that you are able to judge it by yourself now, everybody. So just try to judge and understand it. You will be able to see those rings like you see the rings in a dart. Am I correct, everybody? Am I correct, everybody? Yes. So this is the case of bull's eye maculopathy. Now, as I just discussed, bull's eye is also seen by which drug? Bull's eye also seen by which drug? Chloroquine. Okay. Now you may be asked the question on chloroquine, guys, because you know that because of the COVID-19.
A call from Made in China Zany.
Bull's eye maculopathy. But if I take one dose of chloroquine, will I get bull's eye maculopathy? No. Okay. So the risk for maculopathy occurs when if chloroquine risk if greater than 3.5 milligram per kg. If the dose is greater than 3.5 milligram per kg or greater than 460 milligram cumulative dose. Okay. Or greater than 5 years duration. Greater than 5 years duration. You have been taking chloroquine for more than 5 years. Am I correct? In any of the three cases, you are at more risk of developing bull's eye maculopathy. So it can't develop in a single dose. Single dose are usually 60, 70 kgs. We are so around 70 kgs. We are taking around like 250 milligram, right, guys? So at that dose, we usually do not get bull's eye maculopathy. Done, everybody. Daily dose. Okay, everybody done. Am I correct? Now let's move on, guys. That's all about Stargardt's disease from my side. In terms of signs, there is one more sign left, everybody. So ABC. Now sign number D, everybody. So sign number D is on FFA. There is something called the dark choroid sign, which is also known as the silent choroid sign. Dark choroid sign, also known as the silent choroid sign. So on FFA, there is something called dark choroid sign or silent choroid sign. Now, what is dark choroid sign or silent choroid sign? Again, I will bring up a photograph and try to tell you. Again, for this, I would expect that you remember the normal FFA. If not, then my job will become a slightly more difficult job. Let me bring up a normal FFA also on the screen to explain you. Okay, buddy. So now I'll be showing you two photographs. This is the normal FFA, which I've already explained if you have seen my lecture. Okay, buddy. So in normal FFA, what do we see? We see this optic disc, we see this macula, which is dark, we see the blood vessels. Okay, but what do we see? We also see a background, I can say, fluorescence. We can see a background fluorescence. Can you see the background is diffusely white? Apart from these retinal blood vessels, the background is diffusely white. This background fluorescence is due to choroidal filling. Yes, due to choroidal vasculature filling. This is the normal FFA. Now see the photograph. You understand background fluorescence? I hope everybody. Now see this photograph. In this photograph, do you see any background fluorescence? No background fluorescence. No background fluorescence is seen. Okay, everybody? Because no background fluorescence is seen, that is why we start calling it silent choroid sign or dark choroid sign. Again, I'll just show you this. See this photograph. Background white is white haziness, absolutely black. White haziness, absolutely black. Am I correct, everybody? So this is your dark choroid. See this photograph. Background white is sign. This is your dark choroid sign. Do you understand this dark choroid sign, everybody? This can be asked as an image. I hope you are able to understand it. I hope you are able to wrap your head around it. Everybody who is live and watching right now. Okay. Let's move on to some other conditions of the fundus dystrophies. Very small conditions. One is called as Leber congenital amaurosis. Leber congenital amaurosis. Now, this Leber congenital amaurosis, this is basically affecting a child. Okay, this occurs in childhood, I can say. This occurs in childhood. This Leber congenital amaurosis, this occurs in childhood, and this presents with or causes, I can say, clinical features. Everybody, loss of vision, rod cone at birth, and it also causes nystagmus along with it. Okay, a condition here called as X-linked retinochisis. I'm not going to the detail. I will just write it causes something called as bicycle wheel maculopathy. Just because they may ask you a theoretical name-based question, this is a very rare condition, so I don't think they will ask anything in depth. So just you should know this, that this is a bicycle wheel maculopathy. It causes something called as bicycle wheel maculopathy. Right, guys? And that's all about X-linked retinochisis and Leber congenital amaurosis. Now, to finish my topic of fundus dystrophies, I will do a condition which is actually a symptom: infantile onset nyctalopia. Infantile onset nyctalopia. Okay, everybody, or we call it congenital night blindness disorders. But these diseases are inherited congenitally and they cause night blindness. The night blindness onset is in infancy. So there are some group of disorders which are causing infantile onset nyctalopia. Now, what are the disorders? There are 4 disorders here. Okay, everybody. The first disorder is, I'm going to make a kind of a table here, everybody. The first disorder is congenital stationary night blindness. Congenital stationary night blindness, CSNP. We are going to differentiate these 4 conditions based on ERG finding and fundus finding. The second condition is known as enhanced S-cone syndrome. Let's differentiate between these 2 conditions first. In congenital stationary night blindness, the fundus is found to be absolutely normal. There is no change in the fundus. But the ERG is characteristically negative. Now, what do we mean by negative ERG? If you remember, ERG was like this: 1 negative wave, 1 positive wave, 1 small positive wave. There were 3 waves: 1 negative and 2 positive. But in this case, now there are no positive waves. There is only negative waves. So negative ERG. Am I getting everybody? Now, enhanced S-cone syndrome. Enhanced S-cone syndrome also presents with negative ERG, but the fundus is abnormal. The fundus is abnormal. What is abnormality in the fundus, guys? Fundus has RPE degeneration. RPE degeneration. Okay. Now, the third condition is here: fundus. Squeezing a little, sorry. So the third condition is fundus albipunctatus. If you had seen the mnemonic OMG crap, A for vitamin A deficiency and A for albipunctatus fundus. Okay, everybody. Fundus albipunctatus. In ERG, we say it is normal. Okay, everybody. But the fundus has fundus albipunctatus. The fundus has also what do I say? Abnormality. What abnormality? Not important. Not going into the detail. Okay. Number 4, Oguchi disease. In Oguchi disease, again, the ERG is normal, but the fundus shows a characteristic phenomena which is called as Mizuo Nakamura phenomena. Mizuo Nakamura phenomena. This has been asked, I think, twice or thrice, this question: Mizuo Nakamura phenomena. Okay, everybody. So the ERG is normal, but the fundus is abnormal, and it shows Mizuo Nakamura phenomena. So basically, whenever we see a case of infantile onset nyctalopia, first we do ERG. If the ERG is negative, we know it can be 2 CSNB or enhanced S-cone syndrome. Then we look at the fundus. Then based on the fundus, normal CSNB, fundus abnormal, enhanced S-cone syndrome. If the ERG is normal, then we see Mizuo Nakamura phenomena present. Oguchi disease is not present. Fundus albipunctatus. Am I clear, everybody here? So this is your short summary of infantile onset nyctalopia, which will help you solve questions on it. I can go into the details, but at last, when I tell you the details, I will focus on this table only. So this is a calculated explanation of all these disorders: infantile onset nyctalopia. Done, everybody. So with this, I finished my topic of fundus dystrophies, everybody. I hope you have been able to understand the topic of fundus dystrophies. I will again go back to my starting. Fundus dystrophies are degenerations affecting photoreceptors, so they will either affect rod cells or cone cells. Right, guys? We have done some conditions in this. I just list them for you here. So the conditions we have done is retinitis pigmentosa. We have done Best's macular dystrophy. We have done Stargardt's disease. We have done some miscellaneous diseases, and then we have done infantile onset nyctalopia. if you understand in one way or the other, the main think time all these is either rod cell or cone cell. This will be rod cell. Both these will be cone cell. And because this is nectar, this understand the problem is in rod cell. So whenever the problem is in rod cell, the problem will be of night blindness. But whenever the problem is of cone cell, the problem will be of color blindness or day blindness. And that is the basic ethos of this group, fundus dystrophies. I've shown you 4 or 5 important photographs. One in retinitis pigmentosa, one in Best disease, that was of the IKO Stargardt disease. I've shown you bullseye, I've shown you dark choroid sign. All these photographs are something which will come, which can come. AIMS people usually ask you fundus images, at least 1 or 2 in each exam. Even NEET, because not even more clinical, will ask you such images. So that's it about the third group of disorders in retina from my side, guys. And the third group of disorders that we completed is fundus dystrophies. So we have completed 3 things, guys: retinoblastoma tumor, macular disorders, and dystrophies of the fundus. So now today I'm starting with retinal detachment. So the next topic that I'm starting with today is retinal detachment. So now, my question: what is retinal detachment? Do we know what is retinal detachment? Everybody. Does retinal detachment means detachment of the whole retina? Does retinal detachment means detachment of the whole retina? Yes or no? The poll has started. Everybody, you can answer. Does retinal detachment mean detachment of the whole retina? People are not answering, guys. You just have to click a yes or no. What's the problem, guys? Does retinal detachment mean detachment of the whole retina? Yes or no? What is retinal detachment? Is it detachment of the retina? So, if you again, what is retinal detachment? Retinal detachment is not detachment of the whole retina. It's the retina from the pigment epithelium. Am I clear to everybody? So, retinal detachment is separation epithelium. As simple as that. From RPE. Okay. I just now say what is the investigation of choice. We need to see that the retina is detached. Retina, can it be detached only in the center, or can it be also detached in the periphery anywhere? It can be detached anywhere in the periphery. That means to look at a retinal detachment, I need to examine the whole retina. Because I need to examine the whole retina, I will say that the investigation of choice is indirect ophthalmoscopy. Again, when I have explained ophthalmoscopy, I have explained direct is used to see the center, indirect is used to see the complete retina. I hope you use technology here. That the investigation of choice is indirect ophthalmoscopy. But which other investigation can be used, guys? Other investigation which can be used obviously is OCT. Yes, obviously we can use OCT to be able to see retinal detachment. There is no denying it. We can also use a B.
A call from